So you need to know a little bit about the blood cells, the cells that live in your blood. And they come from your bone marrow, and there's a precursor cell in there, the hematopoietic precursor stem cell. That stem cell can become whatever he wants to become. However, there's two lines that we're thinking about, the lymphoid line and the myeloid line. And on the lymphoid line, you have the natural killer cell, the T cell, and the B cell. And the B cell becomes the plasma cell, and that makes the immunoglobulins. And on the myeloid line, you've got the cells that are going to become the platelets, the megakaryocytes, the red cell line, and the granulocyte line, and the monocyte line. The monocyte is going to become the macrophage, and the granulocytes have little granules in them, so that's the eosinophils, the neutrophils, the other granulocytic, granule-containing cells. And so from an inflammatory standpoint, we'd like to know, are we dealing with a lymphocytic infiltration of usually a combination of B cells and T cells, or are we dealing with a downstream plasma cell problem that is making the immunoglobulin? And that disorder there is called multiple myeloma when it's the neoplastic monoclonal variety. That disorder there is called B-cell lymphoma, and it can be T-cell lymphoma or natural killer cell lymphoma. If it's already left the lymph node, is extranodal, it can be in any tissue, but if it's in the blood, we call that leukemia. So it could be acute or chronic lymphocytic leukemia, acute and chronic myelocytic leukemia, the liquid form of the lymphocytic blood problems, or on the myeloid line, myelocytic blood problems. And on the monoclonal side here, platelets can cause essential thrombocytosis, the red cells, polycythemia vera rubra, and the monocyte and the macrophage, those are the histiocytic proliferative disorders, including Langerhans and non-Langerhans cell types of histiocytosis. These effector cells here, by the time they're already down here, it's unlikely that they would just make a monoclonal process. However, they can cause effector problems based on their normal activity. He's just too much of a good thing. And for eosinophils, the thing you need to know is like eosinophilic granulomatosis with polyangiitis, but there are other eosinophilic disorders that doesn't have to be EGPA, and so it has diagnostic criteria. It can be neutrophil-based disorders where there's autoimmune antibody attack on the little granules that are in the granulocyte, and those disorders are the ANCA-related disorders. They produce vasculitis. Wegener's granulomatosis, now called granulomatosis with polyangiitis, the partner of EGPA, GPA. And it could be other ANCA antibody-associated vasculitides, polyarteritis nodosa, microscopic polyangiitis, a whole slew of small, medium, and large vasculitides driven by inflammatory effector cell. So you need to know a little bit about how blood cells can produce both inflammation and tumors, the monoclonal version of all the cells, or the precursor cell, and the polyclonal version where you just have too much of a good thing. Too much. And if you have too many red cells, that has a name. If you have too many platelets, that has a name. If you have too many white cells, it has a name. And if you just have a structure and use a system, then you won't get confused by these different cell types because they can go wrong on a polyclonal basis or a monoclonal basis. And the monoclonal version we call cancer.